And now I am happy to introduce Dr. Mayor Flansbaum. Dr. Mayor Flansbaum is a child and adolescent psychologist who is passionate about equipping young people and the adults who support them with tools that create lasting change. He specializes in treatment of Tourette syndrome, OCD, anxiety, and ADHD, and is a frequent workshop presenter for educators, parents, and mental health professionals on topics related to mental health and classroom management. Dr. Flansbaum is the founder and director for the Center for Cognitive Behavior Therapy, where he provides therapy in his East Brunswick, New Jersey office, as well as via telehealth throughout New Jersey and New York. He is also a clinical assistant professor in the Department of Child and Adolescent Psychiatry at Rutgers Robert Wood Johnson Medical School, where he has received multiple teaching awards. All right, Dr. Flansbaum, thank you so much for being here, and the floor is now yours.
Thank you so much for the introduction, Alina, and thank you so much to everybody for joining. It's wonderful to be able to present once again for New Jersey Center for Tourette Syndrome for NJCTS, and I look forward to being able to talk to you today about tics, and in particular, we're going to take the angle of when we are new to the diagnosis. So when creating these slides or when organizing these slides, I did have in mind for that these are for individuals who are kind of new to the condition, maybe in the early stages of diagnosis, still trying to figure out exactly what their treatment options are, learning a little bit more about kind of tic disorders 101. I still hope nonetheless that for those of you who are more seasoned and kind of familiar with tic disorders, that you will be able to gain as well. Here's what I'm going to cover today. We're going to talk a little bit about characteristics of tics. We'll talk a bit about diagnoses, the tic diagnosis in particular, as well as some co-occurring conditions, what conditions commonly occur in addition to tics among individuals with the disorder. We'll also talk a little bit about therapeutic interventions, a little bit about accommodations, and a little bit about when and where to go for help. In other words, today's really about a survey or an overview. And I believe this is actually part of a partnership we have with NJCTS to be able to provide a number of workshops. And so consider this to be kind of like the one that piques your interest in the condition. And then we are going to have a couple of colleagues of mine, a couple of veteran presenters for NJCTS are going to be presenting on therapeutic interventions or evidence-based research-supported interventions in general, as well as school-based accommodations and some other topics. So check your email. I'm sure Alina will be sending out information regarding those. So let's go ahead and get started here. This is a generic case example. It's not one individual child, but just to kind of ground us all and get a sense of what tic disorders can look like. Of course, everybody is an individual, and your child or student is going to look a little bit different. John is a 12-year-old boy. And he initially started experiencing some facial movements when he was around 7 years old. He was blinking his eyes for a little bit, rolling his eyes from side to side. And then he had some minor facial movements, such as twitching his nose a little bit like this. And over time, those movements started to move downward on his body, and he had a neck jerk, and he would kind of like jerk his neck to the side like this and lift his shoulder up. He would shrug his shoulders a little bit. And, as time went by, he also began to exhibit some vocalizations like a hum. It wasn't a loud hum. It was enough, though, that it was significant because his parents heard it regularly. And he also made a little bit of a chirp sound. John wasn't particularly bothered by his tics, but it did seem to frustrate his parents and some others in his environment. John also would frequently line up the books and the toys. Everything needed to be in exactly the right place in his bedroom. And when he was writing, doing schoolwork or writing at home, he would consistently write. It didn't look quite right. He would therefore erase it, and then he would rewrite it again, and he would erase it almost to the point where he was getting caught up in trying to get it perfect. Occasionally, he had trouble paying attention in class. He was a little bit disruptive in class, and definitely he was not very organized, so it was hard to keep track of his classwork and his homework. If you have seen somebody like John, then you would see a profile that looks like this. John was diagnosed with Tourette syndrome when he was 7 years old. And he was later diagnosed or also diagnosed with attention deficit hyperactivity disorder as well as obsessive compulsive disorder. This is what we refer to as Tourette syndrome plus or the tic triad. The idea that when individuals have tics or Tourette syndrome, and we'll differentiate between them in a bit, they tend to kind of cluster together with ADHD and OCD. So let's talk just briefly about tics, and then we'll move on to diagnosis and some of the co-occurring conditions. So when we think about tics, this is Gilles de la Tourette, and tics are sudden, rapid, non-rhythmic motor movements or vocalizations. In other words, they are movements that seem to come very quickly, seemingly out of the blue. They are very rapid. In other words, they're kind of like on and off, on and off. They don't seem to follow a particular pattern. Now, tics can have some kind of pattern in that they can occur during certain emotional states or things like that, but they generally occur across situations. And tics can occur in a couple of different forms. They can occur in motor movements or vocalizations. So, motor movements refer to movements of various muscle groups or individual muscles throughout the body. And vocal tics, sometimes referred to as phonic tics, refer to sounds, typically referring to kind of like coming from the vocal cords. But there are also some other kinds of sounds like sniffling, which is why some people refer to vocal tics not as vocal tics, but as phonic tics. It's a little bit more inclusive. So we have different kind of motor tics, different kind of vocal tics, and then also tics can be thought of as being in this category of simple or more complex. And so let's take a look at this tic matrix, and hopefully everything will then make sense for you. So motor tics, simple motor tics refer to motor tics that are coming from one particular muscle group. So they're very kind of quick movements like eye blinking or like a quick nose twitch or a quick shoulder shrug, or movements of different parts of the body. More complex movements are ones that can involve multiple muscle groups, or they kind of have, if you will, a little bit more meaning or meat to them. So instead of just a quick little hand gesture, it kind of becomes like a more, one that involves more movements, in a particular area, or like jumping or touching or squatting. A couple of terms that come up regularly, so I just want to highlight for you. One of them is echopraxia. Echopraxia is imitating movements that other individuals are doing. And corpopraxia is the making of inappropriate gestures, such as grabbing oneself in one's crotch area. On the vocal tic side, we have simple tics are going to be things like a bark or a throat clear or a small chirp. Whereas more complex movements, movements that have more meaning, sounds that have more meaning, are ones where individuals are saying particular words like pancakes, pancakes, or repeating certain words or syllables on a regular basis. And then just at the bottom here to go through a couple of terms quickly that come up, palilalia, echolalia, and corporalia. Palilalia is repeating one's own words. So they might say words, 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 words as they wrap up a sentence. Echolalia is repeating the words of others. And corporalia is saying obscene or inappropriate words. So sometimes you hear this, although it's greatly misrepresented. We hear people like blurting out curse words. So that would be referred to as corporalia. While many people think that corporalia, corporapraxia are very common, some individuals, including professionals, believe that it's part of the diagnostic criteria of Tourette syndrome. That's actually not the case. Corporalia, corporapraxia are actually quite rare. They happen in less than 10% of cases. I have given a number of webinars on the topic of Tourette syndrome, and I often say that I don't have an individual on my caseload that has corporalia or corporapraxia. That's actually the case now as well. So it really is not something so common, but when it does occur, it certainly is very impactful, which is why I wanted to to mention it specifically. I also wanted to mention it because I think it's an area where there's a lot of misunderstanding about within with the world of ticks. So let's talk a little bit about ticks. As we just mentioned, ticks can be simple or more complex. Ticks tend to wax and wane in their severity. In other words, one of the things that we commonly see among individuals with ticks, and parents regularly report this, is that kids are having lots of ticks. Ticks are kind of out in full force, and then all of a sudden their ticks seem to stop or really slow down significantly. And then a couple days later, or a couple weeks later, or a couple months later, they tend to return with a vengeance. They're out and they're strong again, and then they tend to dip again. So ticks tend to, they tend to wax and wane, they tend to go up and they tend to go down. The other thing we often see with ticks is that they tend to morph from one tick to another. In other words, sometimes individuals are blinking their eyes and then the eye blinking kind of slows down or even stops, and then they're moving their mouth in certain ways, and then they're engaging in shoulder shrugs or some other ticks. Ticks do tend to decrease during very focused activity. So lots of times kids who are playing sports or kids who are really engrossed in watching a movie or reading a book will report a decrease in ticks, or parents will report that they don't see their children engaging in ticks. That said, clinically, I do find that there's a lot of variety, that what will result in a decrease in ticks for one individual may actually trigger an increase in ticks for another. So I don't think that you should be concerned or confused if you're noticing that you've read that when kids are engaged in really strenuous activity, they don't tick, but your kid does engage in ticks when he's engaged in that kind of activity. I don't view that as automatically cause for concern. We do find a very consistent pattern, though, about with things that increase the frequency of tics. And so tics tend to be exacerbated by stress or anxiety, by fatigue, and interestingly, even excitement. Tics can impair social, emotional, academic, occupational functioning. However, most kids with tics do not report very significant interference. Many kids still do. However, there are a number of kids out there that would meet criteria for a tic disorder or for Tourette syndrome. However, they wouldn't even describe their tics as really bothering them on a day in and day out basis. Uh, Lastly, one of the hallmark characteristics of tics is what we refer to as a premonitory urge or an urge. Premonitory urge you can kind of think of as being as being like a tickle or an itch, and I think of it as the warning sign that the tic is about to happen for a lot of individuals. Most individuals report the presence of having that urge or that like warning sign that their tic is about to happen. They just kind of know it's going to happen. They physically feel it's going to happen. That doesn't mean it's easy to control, but they have that warning sign. However, there is a subset of individuals, children and adults who don't really report having that premonitory urge. So what does tics look like over time? Typically, the onset is going to be between the ages of 5 and 7 years old. Motor tics typically precede vocal tics. So most commonly, again, we're seeing tics that are going to be muscles throughout the body before the sounds. Generally, tics begin in the facial area, and they tend to move down and out on the body. So one of the most common tics that occurs initially is an eye blink or an eye roll, and we'll talk about the significance of that when we talk about diagnosis. Uh, and then maybe some movements around the mouth like a nose twitch or a mouth movement, and then after that they tend to kind of spread throughout the body. Similarly, we find that simple tics tend to precede complex tics. In other words, it kind of goes from easy to hard in a way. Uh, Over time, what we notice is that tics will tend to increase and then peak around pre-puberty, around 11, 12 years old. And then they tend to diminish in the majority of cases as individuals reach adulthood. So that doesn't mean everybody's going to have it, but the vast majority of individuals will peak at some point during early adolescence, and then their tics will diminish as they enter early adulthood. Excuse me. So, um, in terms of our tick severity, so this chart represents the percentage of clients reporting that their ticks are at their worst. And so what you're going to see here is that ticks are not typically at their worst in the very younger years, and they're not typically at their worst in late adolescence. It's that pre-puberty area, 8, 9, 10, 11, 12, when ticks tend to be most severe. Again, this is based on, there are several studies. This is just one. There are several studies that really support this idea. But I will remind you that studies are really done in the aggregate. In other words, they're looking at, several dozen people, a few hundred people, and occasionally even 1,000 or more people. And overall, this is what we see. There certainly are going to be individuals that fall on either side of the spectrum, where they're going to say their ticks were much worse when they were younger. There are going to be people who say their ticks are much worse when they're older. Let's talk a little bit about diagnosing Tourette syndrome. So, when I think about diagnosis, what I often share with families when I'm giving a feedback after having a chance to meet with parents and meet with a child is I think about this Venn diagram that I have on the bottom right. We have two categories of tics, as we spoke about. We have motor tics on one side, and we have vocal tics on another. When individuals are experiencing, exhibiting motor movements or vocalizations for a short period of time, typically a few months or so, under a year, they have what we refer to as a provisional tic disorder. When individuals have those provisional tics, but then they don't really go away. They stick around for a while. Again, motor tics or vocal tics. And we cross over that threshold of about a year. Then they have what we refer to as a persistent motor or vocal tic disorder. When we have motor tics, multiple motor tics to be specific, and at least one vocal tic, then we have Tourette syndrome, or what's referred to in the medical literature as Tourette's disorder. Um, so I mention these details not because I think diagnosis is the be all and end all. To be candid with you, and I share this with families, whether you have chronic tics, whether you have Tourette syndrome, your treatment really is going to look the same. But there are individuals that come into my office and they say things like, oh, my child doesn't have Tourette syndrome. He has just motor and vocal tics. So the news flash for those individuals is that there is no real practical difference, but just properly, right? They actually, when you have motor tics as well as vocal tics, you have Tourette syndrome. We can call it what we want to call it, but that's really, in the medical literature, in terms of our diagnostic categories, that's what it is. So why do I think that families have that experience? Of course, every family has their own journey through Tourette syndrome. I'm just presenting some, facts and common things that I see along the way here. But I do think that this highlights this hesitancy of saying I have Tourette syndrome. It often comes from perceived stigma in their community, and oftentimes there may be stigma in a community, and my goal is to be able to educate families, to help them be able to be more accepting of the reality of the condition that they have. And I think the more open and accepting we are about it, often the more comfortable we're going to be over time. So, the strict diagnostic criteria for Tourette syndrome are essentially the motor tics and the vocal tics. There are some commonly occurring features, though, which, while they may not be necessary, when I hear about them, they really help me to feel more confident in my diagnosis. So the key one is really a premonitory urge, and that really I think is actually listed. But the waxing and waning of nature, that we talked about earlier, the tics kind of come and go or they change. That's something very common that we see in individuals with tics. Many times individuals report that they're able to kind of slow down or stop their tics at times. Not always, not required. but that they have that ability for very short periods of time. There's an element of control, even though there's not a full element of control. There often is a family history of tics. Three-quarters of the time or so, there really is a family history of tics. There is a subset of individuals, they've actually been studied, where they have Tourette syndrome. However, they have no family history or relatives that have Tourette syndrome. Um, Also, we commonly are seeing symptoms of ODD, symptoms of OCD, symptoms of ADHD, or even symptoms of other anxiety disorders. So, the reason I wanted to put these here to mention these is because I think that when families are new to the condition, and sometimes as they're going through their journey and they're just noticing over the years, their tics are constant, my child's tics are constantly changing. I don't understand. Something must be wrong. Um, that can be really confusing. That can be really difficult for families because there's a lot of change. In reality, that change is actually, to me, what tells me, yes, we are talking about Tourette syndrome. That change is normal. That change is healthy. That change is expected. That's part of the Tourette syndrome experience. What does happen with tics in terms of the diagnosis phase is that tics can be tricky to differentiate from a couple of other conditions. So I just wanted to highlight a few here. When we talk about tics, as I mentioned, tics typically have very sudden, non-rhythmic. They don't really have a clear pattern movement. No matter what's going on, the individual is going to engage in their tics. Certain situations in the environment may exacerbate the tics, they may make them worse, they may help to mitigate the tics, they may make them better. However, the tics are typically going to happen across settings. OCD is a little bit different. OCD isn't really about sudden repetitive movements, but actually it's about oftentimes repetitive thoughts, repetitive images, repetitive impulses. Those elevate anxiety for individuals, um, and therefore they engage in certain behaviors that result to try to alleviate or ameliorate that level of anxiety. So, for example, an individual may be very concerned about getting sick or collecting germs, and therefore they engage in a ritualistic behavior of or repetitive behavior of washing their hands. Now, you might say, okay, well, that clearly doesn't sound like tics. But what also happens at times is individuals may have a certain thought or image or impulse that makes them think something bad is going to happen. And then what they end up doing is they end up engaging in a tapping behavior, right? And the tapping behavior is really their compulsion. It's really their behavior they're doing to alleviate their anxiety. But when people hear or see tapping, right, that's one of those sudden repetitive movements to a lot of people. It can feel like tics to certain providers, when in fact it's not necessarily. Stereotypy, common among kids with autism. Kids may engage in rapid, you know, kind of very rhythmic pattern movements, like they may flap their arms or something like that. Um, Again, different type of behavior than a tic, but often confused with tics. Similarly, repetitive behavior, because people hear tics, people think repetition, but self-harm, oftentimes intentional, for example, cutting or hitting oneself or biting oneself. It is a form of self-harm. It is a form of repetitive behavior in a way, but it's not really, it's very distinct from tics. So tics versus OCD stereotypy or NISI, non-suicidal self-injury, they're very different. A couple of other areas to kind of distinguish between them. So when people think about tics, tics, I think of actually, I shouldn't say people, I think of tics as being what I would call semi-voluntary. In other words, tics are not really involuntary movements. They don't really happen, completely, unprompted. They're typically, as we mentioned, is an urge, right? People have an urge. And actually, the premise of treatment for tics is that individuals can have an urge, and because they experience that urge, they then are prompted to engage in the tic. So, in a way, the tic is a voluntary movement. At the same time, individuals can't really stop their movements from happening. Therefore, That's why we say you can never punish it, should never punish a child with tics because they are ticking. It's kind of out of their control. So it's really not either of those extremes. And I would say actually the tics really fall into this category of a semi-voluntary movement. That's different than a stereotypic behavior, which is more automatic. Um, and it contrasts with OCD, for example, where individuals are saying, yes, I'm now about to engage in this behavior in order to free myself from being cursed or something like that. And then when we go to function, we notice some differences as well. So tics are really designed, tics are really exhibited, we think of from a behavioral perspective, to alleviate an uncomfortable urge. Think about having a mosquito bite, and then you scratch the mosquito bite in order to get the relief from that physical sensation. Whereas OCD is typically decreasing some kind of anxiety. Stereotypy is on the other end of the spectrum. It's typically perceived as a pleasurable activity. And then self-injury is typically done in order to be able to regulate emotions. So when we really understand these different conditions, we can recognize they're very different. At the same time, there is a lot of confusion at times when they're being diagnosed, depending upon doing your who is doing your diagnosis. So let's talk a little bit about what happens with diagnosis and who does diagnoses. One of the common things I notice is what I call doctor hopping. And I share this with you not just based on having a lot of data. I don't have a ton of data on this, but this is something that I see very regularly as a specialist treating Tourette syndrome. My colleagues talk about this as well. The idea of doctor hopping is that individuals will bounce from one doctor to another, trying to figure out what is going on with their child. And this all really aligns, I think, with the pattern of tics. Oftentimes, tics begin with some kind of eye blinking or eye movement, and parents are concerned that their child is having trouble seeing or that something is going on with their eye, so they go to the ophthalmologist or they see an optometrist. Um, then then those movements from the eye become sounds in the throat. If it's something going on in the throat, then parents are taking their child to an ENT, or they may be thinking about maybe a gastroenterologist because something might be going on in their stomach. Um, Occasionally, kids have tics that result in kind of like breaths in, breaths out, the way they're moving their mouth. So there's concern that, oh, well, maybe this is a breathing issue. What if something is going on in his heart? And then they go to the cardiologist. So not everybody has this entire experience, but oftentimes individuals are going to bounce from doctor to doctor. A study that came out just last year said that the average time between initial noticing of tics and diagnosing of tics is about 1.7 years. I would actually say that's pretty good. I often notice significantly worse, and I suspect if we look at back literature, that gap was even larger. Um, 50% of families, in one recent study, 50% of families reported seeing three professionals before they received a proper tick diagnosis. This is, I think, a significant barrier. Again, this happens because of a lack of specialists in the area of Tourette syndrome. There's a lot being done to try to address this, and at the same time, I think there is still continued work to do. Professionals self-report a lack of confidence in diagnosing tic disorders. Um, Again, that makes it more difficult to be able to have a prompt diagnosis. And then, so while the primary piece, I think, in terms of barrier is having competent professionals, competent clinicians, I also think symptom overlap can make tick diagnosis confusing. So I wanted to share a little bit of research on this just to kind of highlight this challenge that we're having in our field related to provider knowledge about ticks. Um, in one study, 31% of providers shared that they didn't feel confident in diagnosing ticks. And you might think that that's not a huge number, but if you, let's say, think about all the pediatricians there are, and we say that approximately a third of them aren't comfortable diagnosing ticks, that's a lot of clinicians, right? That means we have a 66% hit rate for clinicians comfortable diagnosing ticks. That leaves a 33% rate of clinicians, who are not meeting we're not meeting kids' needs. Similarly, there's been studies giving physicians, giving psychologists, giving nurse practitioners a basic knowledge test about Tourette syndrome. One of these studies was done by a student of mine for his dissertation, and we found that the doctors across these studies are getting between, up in the 70s for their TS knowledge test. Again, you might say that can be pretty good. It could be a lot worse. My response would be, when was the last time that you went to a doctor and said, I think my child is sick. I'm really looking for someone who got C's throughout medical school. That's really my target. And of course, none of us are looking for that, right? And so this is, I think, highlighting that we need to increase the knowledge surrounding Tourette syndrome. This is unrelated to knowledge of Tourette syndrome diagnosis, but I did want to highlight it. A study found that 35% of providers have heard of habit reversal training, or CBIT, Comprehensive Behavior Intervention for Tics. So 1 out of 3 are not knowing the primary evidence-based treatment for tics in addition to medication. And so I think, broadly speaking, this is really the challenge that we have in the field of Tourette syndrome. When we have gaps in knowledge, then it's hard to be able to diagnose kids. It's hard for kids to know that what they have is tics and that their help is available. And this speaks to the importance of advocacy from organizations like New Jersey Center for Tourette Syndrome, Tourette Association of America, and others, in order to be able to build awareness, which translates to better treatment ultimately for kids struggling with tics. Let's talk a little bit about co-occurring conditions. So I mentioned earlier about Tourette Syndrome Plus. Here's a brief diagram about Tourette Syndrome Plus. I updated this just yesterday for this talk with a couple of more recent studies. But generally speaking, what we're going to find is when individuals have tic disorders, or Tourette syndrome in particular, they are very likely to have ADHD. Almost half of kids are going to, who have tics, are going to have ADHD. A large chunk of them, 20-30% or so, are going to have OCD. Another chunk of them are going to have non-OCD anxiety disorders. So these are things like separation anxiety, generalized anxiety. The depression one is a huge range. Studies show a huge range. I previously had a huge range on this slide, so I was really excited to look up and see more recent research, because I see very few individuals with depression co-occurring with their tics. That doesn't mean it doesn't happen. And I will tell you that even as recently as 2025, right, there are studies that seem to be showing that in certain samples, depression is pretty prevalent. Kids with tics are more likely to have learning disorder. They do have, there is a small percentage of those individuals who are going to have autism. Mostly, that actually looks like a typo, I believe. I'm sorry. Mostly, I believe it's about 2 to 10% in studies, not 20% like I drew up there. And a significant number of kids with Tourette syndrome also have social skills challenges, just difficulty getting along with friends. That likely is accounted for more by kind of the autism and ADHD piece, but I did really want to mention it here. Excuse me. So, so why are we talking about comorbidity so much? Because comorbidity is really the norm. I previously trained in and worked in a couple of Tourette syndrome specialty clinics. And I often spoke with my colleagues about how much of what we treat in the clinic is actually not tics, but the co-occurring conditions. Co-occurring conditions, the anxiety, the ADHD, the difficulty listening at home, the challenges parents are having managing their child's behavior, those co-occurring conditions are often more impairing on a day-to-day basis than the tics themselves. And so what this means is that when you have a child with tics, it's really important that you are seeing a specialist who understands tics as well as the co-occurring conditions, which typically is the way tic disorder specialists work. They have a good understanding of tics. They also have a good understanding of anxiety, OCD, often school refusal, and certainly ADHD as well. On the other hand, what this also means is that kids with tics can see providers who don't have expertise in tics because oftentimes we're not treating the tics themselves, but we're treating those co-occurring conditions. I find that many families who have kids with tics prefer working with someone who understands tics, even if they're not being treated, because, like I said at the beginning, tics really wax and wane. And when they're out in full force, kids have questions about them. They want to know what to do about them. They want to be able to cope with them, and that can be helpful. However, it's challenging to find providers with expertise in tics. And if you have tics, but you are really focused on OCD, then you don't necessarily need an expert in tics to be able to address it, although it does depend. Let's talk a little bit about therapeutic interventions. Before I begin this section, I really want to highlight that in about a month, a colleague of mine is going to be giving a workshop on evidence-based treatments for tics, and I'd encourage you to attend that because there are a host of treatments. I'm really going to highlight the two main ones, which are medication and behavior therapy. But there are other cool treatments that are out there. They have very small research base. They're almost kind of like in the pilot stage, but they are out there. They're worth learning about. I also think it's important to know at the beginning of your journey with Tourette syndrome, there are a lot of treatments out there that are very popular and very not research based. There isn't evidence to suggest they work, and so I think it's important to be aware of them. Just because a treatment doesn't have a lot of evidence to show it works doesn't mean it's bad. But it can mean it may make sense to think about, should I be doing this treatment? Should I be putting my limited financial resources here, or should I be focusing on another one if I haven't tried some of those other core ones that have been shown to be effective? So there's a lot out there in terms of therapy for tics. We're going to talk about a few different therapy interventions just briefly today. Um, Number one, behavior therapy, counseling, etc. So therapy is a very well researched approach for managing tics themselves. In other words, when your tics are happening more frequently, what can we do to be able to slow them down or suppress them? How can we give you a strategy to be able to manage your tics? Um, Another piece to that is living with tics, right? There's kind of like reducing the tics themselves. And then there's how do I live life with tics? Because tick treatment is really not cure, it's management. We are learning ways to be able to uh, reduce the frequency of our tics, but we cannot make them disappear. How do you talk about your tics? How do you respond to people who are teasing you or bullying you about tics? How does that response differ from when it's a good friend of yours who's just curious? The other piece that comes up a lot in therapy, like I mentioned before, is managing those co-occurring conditions. So, OCD, ADHD, anxiety have good, solid, evidence-based treatments out there. Just to name a couple, for OCD, we have exposure and response prevention. For anxiety, we have exposure therapy. These are therapies you can think of loosely as being facing your fears, learning to experience discomfort, right? And not engage in avoiding the uncomfortable feelings that you're having. For example, you might be nervous or uncomfortable about um, raising your hand in class, and at the same time, you can raise your hand and speak because you'll, in the end, be okay. Exposure therapy, exposure and response prevention, ERP, are typically done by specialists. They are not just throw you into a pit with snakes, but it's done in a gradual and supportive way when it is done correctly. The other common one is treating ADHD. ADHD is typically treated on a behavioral level using behavioral parent training. Um, Strategies to help parents be able to maintain the positive relationship they have with their child or continue to build it if it needs a little bit of retooling, to be able to positively attend to the positive behaviors your child is exhibiting, and to be able to set effective limits in a supportive way. Timeout is a part of that as well. It's typically not a go-to strategy, but it's certainly one that following building that positive foundation and setting effective limits, timeout becomes very important as well, or can become very important. So that's the therapy. Medication. Medication is a very appropriate way to treat tics as well. There is good literature supporting it. There's also good literature supporting treating OCD, anxiety, ADHD with medicine as well. Lastly, while it really isn't a therapeutic intervention in a way, it is an important intervention. Which is school-based work, working with families, working with schools, helping teachers understand what tics are about, and at times helping students to be able to understand what they are about as well. Let's talk briefly about behavior therapy for tics. The treatment package for behavior therapy for tics is typically referred to as CBIT, or Comprehensive Behavior Intervention for Tics. CBIT is a treatment. It was developed by Doug Woods, John Piacentini, and several colleagues of theirs, and it has a few different components. It's built on the foundation of habit reversal training, or HRT. So behavior therapy for tics, you'll typically hear being called CBIT or HRT. Um, Education is really the foundation. I spend a lot of time helping kids understand their tics as well as helping their parents understand their tics. The core component then is building awareness. When is my, how can I describe my tic? How do I know when my tic is exhibited? Can I raise my hand every time I do a tic? And following that, can I raise my hand every time I know I'm about to do the tic? Again, at that urge. Once individuals are aware of when they're about to do their tic, then they're ready for their what we call in my practice, the tick buster. The tick buster is really just the child-friendly name for the competing response. The competing response is a behavior that you engage in that is incompatible with engaging in your tic. So, for example, if you flail your arm out to the side, we may talk about crossing your arms to give, a simplified example. Social support is really having a coach, someone to be able to help you. It's very hard, especially for kids, but for adults as well, to be able to monitor their tics, to be able to pay attention, to be able to remember their strategies. And so that's why we have awareness training, competing response training. We give kids coaches as well. Coaches are typically their parents. Occasionally, for older kids, it's a friend. Some other components that are a part of CBIT, one is function-based intervention, and the other one is relaxation. Function-based assessment and intervention, FBA, refers to really understanding the environment that tics are in which tics are occurring. And so think about it as your ABCs, your antecedent, your behavior, and your consequence. Your B is your behavior. That's in the middle. That's your tic. Prior to your behavior happening, something occurs. There might be something occurring. It might be an emotional situation. It might be an emotional state. It might be a triggering environmental situation where you are. And after your tic occurs, something occurs as well, like maybe you feel a sense of relief. By modifying what happens, particularly before, but sometimes afterwards as well, um, we can actually shape and increase or decrease the frequency of tics. Of course, we're focusing on decreasing the frequency of tics. So Dr. Woods and his colleagues focus very heavily on function-based intervention, followed by habit reversal training. Other clinicians may focus a little more on HRT and kind of add in your FBA. So that's behavior therapy for tics. Pharmacological approaches for tics. So there are a few core medications that are used for treating tics. These slides are a little bit dated, and generally speaking, the information is about the same. I will note, though, that there are a couple of slightly newer medications out. There's a newer version of guanfacine that just came out recently. That anecdotally, one of my psychiatrist colleagues has been speaking very highly of. There also is, and I believe it's an antipsychotic, drug that came out, a neuroleptic or similar to a neuroleptic in effectiveness, but it doesn't really carry a lot of the same profiles. So there are some, there are some new changes, in the Tourette syndrome medication literature as we speak. So the most effective treatment for tics is going to be the neuroleptics or the antipsychotics. The challenge with those drugs, though, is that they have very significant side effect profiles. For example, significant weight gain. That's why the American Academy of Neurology American Academy of Child and Adolescent Psychiatry generally focus on the alpha 2 agonists or the antihypertensives as the first line medication intervention. So these are going to be clonidine and guanfacine. Guanfacine is 10x, is the brand name that you probably hear about. That's a short-acting one. I didn't put it on here, but Intuniv is another popular name, and that another popular drug. That's kind of like guanfacine you can think of in I believe long-acting or extended release form. Um, Botox is an intervention. There are other interventions out there, certainly on the pharmacological realm. So, what do we do with our ticks? There are different algorithms you can use. The most important thing I would recommend is getting a good diagnostic evaluation. A good diagnostic evaluation is going to cover not just your ticks, but it's really going to ask about, the totality of life, and the totality of, psychological, psychiatric symptoms that your child is experiencing. That said, just for, giving a little bit of background, I do think that these kinds of algorithms I find families like them. It kind of grounds you a little bit in terms of what you're looking for. And these are based on, based on some, pretty established parameters. For example, this algorithm here is highlighted in the practice parameters for Tourette syndrome in the recommendations made by the ACAP, American Academy of Child and Adolescent Psychiatry. So they're pretty, they're pretty rigorously, evaluated protocols. So mild tics, typically mild tics can often be addressed with just education for the child, education sometimes only for the parent, and what I call watch and wait. You'll pay attention, you'll see what happens. If it gets worse, you want to be ready. Other times, mild tics are generally addressed with behavior therapy. Medication is generally not indicated for mild tics. Medication is usually your better way to go. That said, every child is different and there may be different kinds of experiences at play, such as a need for more immediate results. A child is not going to comply in therapy, right? There are different reasons to consider medication over behavior therapy. There are, of course, different reasons to consider behavior therapy over medication. Moderate tics, when tics are more mild to moderate, we kind of do the behavior therapy thing. When tics are more moderate to severe, then that's where alpha 2 agonists can come into play, like guanfacine or clonidine. They might be used alone or they might be in conjunction with behavior therapy. And then when they're more severe tics, so that's when we're thinking more about the need for the neuroleptics, because if we don't have to use them, we really try not to because of the side effect profiles. Again, this is where everyone's individual situation needs to be looked at individually. Let's talk briefly about the classroom, and then we'll wrap up talking a little bit about support. Tics can be very impactful in the classroom. Many kids find their tics themselves to be distracting. And that's where one of the challenges comes in terms of diagnosis. Diagnosing tics can also be confused, although I talked about where it really mimics the same in terms of stereotypy, in terms of OCD. Tics can really be confusing with ADHD as well. For example, ADHD is a condition marked by three hallmark symptoms: inattention, hyperactivity, and impulsivity. That inattention piece, kids seem to be struggling. They seem to be looking away a lot. That could be because there's raw inattention there. There's a difficulty with being able to focus, and that's why they're looking out the window. But the other thing that could be happening is, think about a child who has a little vocal tic or a little nose movement that he doesn't want to be exhibiting. He doesn't want to distract his peers. And so he's spending all of his time focusing on that. No wonder she they are unable to pay attention as fully as they would like in their classroom. So tics can be distracting in the classroom because of because they are because you're engaging in them. Kids may find them painful. Kids may be ashamed of them. Occasionally, kids are worried about being teased or bullied because they are more likely than the typical kid to be teased or bullied, given that they have their tics. Peers may find them distracting or they may find them frustrating as well. So what do we do about it? There's a lot that we can do about it. We have a whole talk on Tourette syndrome in the schools, but I wanted to just highlight a couple for you today. The biggest one is education increases acceptance. Teaching other students in the class about tics, or really even teaching the teacher about tics, I think is key. Students often follow the lead of their teacher. If teachers are telling kids, hey, stop that noise, why are you making that noise, or trying to work here, then students are going to follow suit. If teachers are not doing that, oftentimes teachers ignore, students ignore as well. And that really is what we want kids to ultimately do when an individual is ticking in the classroom. So understanding tics helps to breed a level of acceptance. What starts off as kids are doing something annoying becomes actually, oh, they can't help it. I understand. I can learn to ignore it. Sometimes we do this by having an in-service presentation made by a professional, made by an outside doctor, made by an organization like NJCTS. Other times it can just be the student having a short little, 3-minute talk to his class and answering questions to the best of his ability. We never force this on a child, but it is something to consider. Breaks. So, allowing students to be able to take breaks, just to be able to tick, to be able to move around, let them have a safe place where they don't need to feel ashamed about engaging in their ticks. That can be really helpful. At the same time, we're balancing on the one hand, giving a kid a break. On the other hand, we're ensuring that that child is not using the strategy so that they can avoid math class or history or whatever it is that they don't want to be engaged in the school process. Thoughtful seat placement is something that I find really helpful with kids with tics. Don't stick the kid in the back left corner if the child doesn't want to be in the back left corner. At the same time, we don't need to put a child who's squirming around in his seat front and center either. If a child needs to learn, we can put them in the front on the side. So I think just being thoughtful about where kids are placed can make a big difference. Work accommodations I mentioned here because that's something that can be tricky. Kids should not be removed from the classroom because they have tics. They should be forced to be removed rather. However, there are times where kids have very significant vocal tics and they may self-volunteer to take their tests somewhere else if they don't want to then frustrate some of their peers. Testing accommodations also can be helpful if tics are really slowing kids down. Then to be able to have some extra time to be able to take it in a quiet space could be helpful. Ultimately, tics at school, the goal is really to make tics irrelevant. In other words, it's not that we can't talk about them, but we don't want kids constantly having to answer questions about them. We definitely don't want kids having to constantly be teased about them or bullied about them. Let's spend 5 minutes talking about getting support or a few minutes, and then we'll wrap up. I'd love to take a few questions. I have another 15 minutes or so after I wrap up. When and where do you find support? So first of all, when should you seek support for tics? The textbook answers are right here. Tics are bothersome to you. Tics are causing to the child. Tics are causing academic difficulties. Kids are causing social difficulties. Ultimately, what I find when kids are struggling with tics, it makes sense to get help. But sometimes when kids are just exhibiting the tics and they have some questions, that can be time to get your initial evaluation. Um, and the reason you want to get that evaluation is to make sure that you know what you're dealing with. Just because you get an evaluation doesn't mean you need to seek treatment. I regularly will do like a little consult. I have other colleagues who do like a little 2, 3 part consult just to kind of help you understand what's going on. I think that's perfectly appropriate for initial stages of treatment because it can help you understand. And I would say in most cases, ease your anxiety. I think most of the time, I have no data to back this up, but most of the time I see parents are worried and they're worried understandably. It's your child. I have children. I worry about them also. Most of the things we worry about, we're worrying about a little bit more significantly than there is actual harm or danger, on the horizon about. And so I find that education actually calms families down rather than increases their level of anxiety. So even if you're not like ready for full-blown treatment, it can be helpful to have that initial evaluation. So how do you find a specialist? There are a few options. there was actually a study I read that found 70% of people are finding their initial tick specialist from a pediatrician. That sounds about right. The challenge, of course, is whether your pediatrician knows tick experts. Um, so I think another really good source are education and advocacy organizations like NJCTS, like the Tourette Association of America, local chapters in whatever state or city that you live in. Psychology Today, or just searching Google, another good way to find therapists, who specialize in ticks, and then friends and community members, um, and asking a school counselor. Um, the more specialized you need, the more niche it becomes to try to be able to find your expert, whether it be about Tourette syndrome or any other relatively rare condition relative to the more common ones. How do you find the right provider? So first of all, you have different options. There are psychologists, there are psychiatrists, there are neurologists, there are also a range of counselors and social workers. I really want to differentiate between psychologists, psychiatrists, and neurologists because um, there's confusion sometimes about what each of them do. A neurologist and a psychiatrist are typically going to treat the same way. They have slightly different mindsets when it comes to diagnosis, but overall they should be very similar. A neurologist, typically you want one who has experience with movement disorders. Neurologists may be, in my experience, they're pretty familiar with Tourette syndrome, but they're not as familiar with the nuances of ADHD, OCD, anxiety, generalized anxiety, separation anxiety, etc. A psychiatrist, I find often, and again, there's no data. This is just, Mayer's experience here. Many psychiatrists I find are really well versed in terms of the mental health aspect. They see anxiety, OCD, ADHD all the time. They really don't see a lot of Tourette syndrome cases. And then there are psychologists. Psychologists are going to be versed in Tourette syndrome or anxiety or OCD, ADHD, but they don't have the medical background to necessarily rule out certain other conditions, when we're seeing different kinds of movements. Ultimately, I think it doesn't actually matter. I wouldn't recommend going to this doctor versus that doctor, in a blanket way. What I think is important is that you look for an expert rather than go to a jack of all trades, a generic counselor, a generic neurologist, generic psychiatrist. I'd look for someone who really has expertise in Tourette syndrome, who sees a lot of those kinds of kiddos. So do your homework, read up on your doctor. After you read up on your doctor, request a short call and try to do a little assessment. How often do you see clients with tics? What type of therapy do you provide? What type of medication do you provide? Listen carefully, whether it seems like they've done this a lot or whether you're the third person in their career that they've seen, with potential tics. Think about, whether they're mentioning, oh, I believe, that like the antipsychotics, the neuroleptics are the way to go, or, I do some kind of behavior therapy for it. You want people who are kind of recommending inconsistent with the guidelines that I mentioned earlier. HRT, CBIT, you know, typical first line being, kind of like the alpha 2 agonists. Again, every situation when you get in the room may be different, but those are the general rules of thumb. And so that I think is what you're looking for when you're looking for a provider. The last thing I would mention on this is that knowledge is power. Don't be afraid to get a consult with a provider from another discipline. If you're one of those people who's like, my kid is going to therapy, great, send your kid to therapy, go to a psychologist, but don't discount the role of medication. Um, Going to the psychiatrist or neurologist doesn't mean that you're not going to doesn't mean you need to take medication, but you can learn about it. And a lot of times you can gain valuable perspective like that. And similarly, I like families who are like, I'm requesting medication. That's what I want. That's what my schedule allows. Great. But know about what your options are in terms of therapy. Neither of these treatments works automatically alone. Sometimes we need the combination of the two. And so it's good to be able to have options. And lastly, as I wrap up here, I think it's important to keep in mind that, when we talk about kids, particularly, beginning to talk about Tourette syndrome, we're talking about diagnosis. We're talking about, is it this condition? Is it that condition? Is it Tourette syndrome? Is it OCD? Is it Tourettic OCD? Is it, some combination of multiple of those conditions? And what's the treatment we do to reduce their tics? That's all important. But at the end of the day, kids are so much more than just their tics. When I'm working with kids, I do this activity with younger kids. It's called a me box, where we basically create a cube and I ask them different questions on different sides. And one of them is, what are my tics? What are some tics that I do? And what I'm trying to highlight for those kids is that tics really don't define you. Tics are just one piece to the big puzzle of the complicated, awesome you that your child is. So that's what I got for you. I'd be glad to take some questions here publicly. If you do have questions for me, you can also email them to Alina if you'd like them to be anonymous. You can email them to me if you'd like my answers. And you have no problem emailing them to me. I'd be glad to. I'd be glad to assist and be a resource to you as you're going along on this journey. In other words, you don't need to email me only if you want therapy. I don't need to work with you, but I'm happy to answer a couple questions because I know how difficult this journey, how confusing this journey can be for you.